So welcome to today's session on standard precautions, transmission-based precautions, and enhanced barrier precautions for long-term care facilities. So a few housekeeping items. Today's session will be about an hour long. We will not pause the webinar content for any questions. However, we did reserve time at the end for a live Q&A with myself and medical consultant, Dr. Kearney. Continuing education requirements. This is a 60-minute session approved for one contact hour. The CNE participants, this nursing continuing professional development activity is approved by the Northeast Multi-State Division Education Unit and accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. It's always a huge mouthful. All 4 steps ahead of you, in front of you, are required, including a post-session quiz, and that link will be emailed to you tomorrow. If you are here to receive EMS, dental IPC, and then general certificates of training, you do need to complete steps 1 through 3, and the post-session quiz is optional. If you want to fill that out, go for it. So for those of you who don't know me, I just want to take a moment to introduce myself. My name is Allison Thurber. I have been a nurse at Rhode Island Department of Health for about 7 years in the Center for Acute Infectious Disease Epidemiology, and I'm so happy to be with you today. So we will get started. Let's start with our agenda. So our agenda includes welcome and introductions, which we kind of went through. Then we'll discuss MDROs and infection risks in long-term care. We'll go over the 4 elements of germ spread and pathways of infection, review of precautions. We will compare in more detail transmission-based precautions and enhanced barrier precautions. We will go over implementation of precautions in long-term care facilities. We'll have a case scenario that we follow throughout the webinar, and then at the end, we'll kind of summarize everything nicely. We'll do some key takeaways, announcements, end of session feedback, and our Q&A. So today's learning objectives are to define multi-drug resistant organisms, also known as MDROs, and describe their impact in long-term care. Explain the 5 elements of germ spread and pathways of infection, kind of like a back to the basics thing, just making sure that we know our pillars. Differentiate between standard, transmission-based, and enhanced barrier precautions, and then recognize when to apply each precaution and use them appropriately. All right, so as mentioned throughout this training, we'll follow an example patient case that we can use to illustrate infection and prevention control strategies and hopefully apply them to our facility. So our case is going to be Mr. Jenkins. Mr. Jenkins is an 82-year-old male living in a long-term care facility. He has moderate dementia and often needs cueing during activities of daily living. He has a chronic Foley catheter and a wound on his sacrum. Because of this, multiple staff have hands-on contact with him throughout the day. He enjoys attending group meals and facility activities like bingo regularly. Mr. Jenkins was also recently hospitalized for pneumonia and returned to the facility on new antibiotics. So we'll use Mr. Jenkins' story to see how standard precautions, transmission-based precautions, and enhanced barrier precautions apply in real long-term care situations. We're going to start everything off with just discussing MDROs in general, multi-drug resistant organisms. Just want to see if we have Oh, okay. Looks like the chat's working now. Awesome. Thank you all for troubleshooting that. Okay. So multi-drug resistant organisms, also known as MDROs, are germs that have developed resistance to antibiotics. Examples of these include MRSA, VRE, CRE, and Candida auris. These germs pose a very significant risk in long-term care because once introduced, they can spread quickly among residents with wounds, devices, and frequent care needs. And to understand MDROs, we must understand the difference between colonization and infection. Colonization means that the germ is present in or on the body, but isn't causing illness. While the person hosting the MDRO is asymptomatic, they can still spread their germs to others. So while both colonization and active infection pose risk, they can require different types of precautions while in long-term care facilities, which we will discuss today. So residents like Mr. Jenkins who are living in long-term care have unique vulnerabilities. Many have indwelling devices, open wounds, recent antibiotic exposure, or weakened immune system. They also share common spaces. Think dining rooms, therapy rooms, activity rooms. This all makes transmission much easier. So think about Mr. Jenkins. He requires help with bathing, dressing, Foley care, wound care, and transfers. Each of these interactions is an opportunity for germs to spread. So why are long-term care residents at higher risk, like Mr. Jenkins? Well, they have frequent close contact between staff and residents. They share equipment and rooms. They have chronic conditions and weakened immunities. Extended lengths of stay. So they're at these facilities. They're sometimes living at these facilities for the remainder of their lives. This is their home. They use invasive devices. There are frequent hospitalizations usually associated with long-term care residents, and also antibiotic exposures. So this figure in front of you illustrates what we call the iceberg effect of MDRO colonization in nursing homes. So a study was performed in Southern California on nursing homes, and of 28 nursing homes, only 4% of colonized residents had a documented MDRO history. An additional 44% were detected through active screening. So what does this tell us? This tells us that a majority of MDRO carriers are unrecognized and driving asymptomatic transmission. On average, 50% of residents in this study were colonized with an MDRO, and some facilities even exceeded 70% colonization rates. MRSA, ESBL, VRE were the most common organisms. Environmental contamination was also seen widespread throughout the facilities, with over 90% of common areas testing positive for MDROs. More recent data confirms that these trends are worsening, with CRE colonization increasing significantly among patients transferred into long-term care. So residents like Mr. Jenkins move between hospitals and long-term care facilities, and hands-on care creates frequent opportunities for transmission. For current MDRO and CDI, also known as C. diff infection, data collection forms and protocols, if you'd like to institute some of this in your facility, please refer to the link that Kelly is going to put in the chat for you. Thanks, Kelly. All right. So here's where we're going to go, I feel like a little bit backwards. We're going to just talk about germs in general. So germs are part of everyday life. They're found in our air, our soil, our water, and in and on our bodies. Some germs are helpful, other germs are harmful. Many live in and on us without causing any harm, and some even help us to stay healthy. Only a portion of these germs are known to cause infection. So over the next few slides, we'll review the 5 elements that contribute to germ spread and cause infection. And as we go through these slides, I would like you to think about where germs possibly spread in your facility. What's common in your facility? What do you see in your facility? Where do you think is risk for germ spread? So germs can live, again, both in the body and on the body and in the environment around us. In the human body, common reservoirs include the skin, the gastrointestinal system, the respiratory system, and blood. So go ahead and think of some resistant organisms that live on skin. You can put some thoughts in the chat if you'd like. I can think of MRSA. I remember I had a nursing student friend in college, and somehow when she shaved her leg, she ended up getting MRSA into a wound, and nobody knew anything about it because we were just college students. And we were panicking, thinking like, oh my gosh, we're all going to get MRSA. But that is a common MDRO that happens to infect the skin. Also, Candida auris is one of them. So in healthcare, aside from in the body, germs can also live in the environment, and germs can live and thrive on water and wet surfaces, dry surfaces, dirt and dust, and medical devices. So think about devices we use every day: blood pressure cuffs, glucometers, stethoscopes. They can all harbor bacteria and help spread germs from one resident to the next. When you understand where the germs are found and how they travel, you can then spot opportunities for spread and take the right steps to protect yourself and all of your residents. So infection happens when all 5 of these elements of how germs spread and cause infection line up perfectly. So first, you need a reservoir where germs live. You need a pathway for the germs to travel. You need a susceptible person to receive it. You need a weakness or breakdown in the body's natural defenses. And then you need conditions that allow the germ to survive. And again, all 5 of these things need to be in perfect alignment for there to be an infection. In healthcare, like we mentioned, there needs to be a way for germs to spread or get from one person to another or one place to another. And we call these pathways. And that is one of the 5 elements. So there are 4 pathways for germs to spread from reservoirs. The first is through touch. This is usually involving the skin, especially the hands, but also devices that contact different people and surfaces. The second is through splashes and sprays of blood, body fluids, or water. So germs in those splashes can then enter your eyes, your nose, your mouth, or breaks in the skin and cause infection. The third way is through breathing in, when you breathe in small infectious particles. And the fourth way is through clinical care tasks that bypass or break down the body's natural defenses. So an example of this could be like inserting an IV. This leaves an entry point that's unavoidable if you're putting an IV in for germs. And this creates an opening area in the skin, and then germs can get in that area. All right, so back to Mr. Jenkins. Let's just pause here and think through Mr. Jenkins' morning care. So Mr. Jenkins has morning care routine, which consists of a wound dressing, catheter care, and assistance with hygiene. During morning shift, staff are preparing to assist Mr. Jenkins with his wound dressing changes and Foley catheter care. These are high contact care activities that involve close hands-on contact. So if you're a staff member and you're going to take care of Mr. Jenkins, what sort of things should you be thinking about? You should be thinking about what precautions apply to Mr. Jenkins. Does he have precautions? Does he have an active infection, or is he colonized with an MDRO? Are there wounds or indwelling medical devices present that change how we approach our care for him? And if you ask these questions before, it should lead you to thinking about precautions and pathways. So the first pathway, as we mentioned, is touch. Germs can be spread through touch, usually by the skin and hands, as well as by devices. So when we help Mr. Jenkins with transfers, bathing, dressing, or Foley care, we're touching surfaces, devices, and his skin repeatedly. Without proper hand hygiene and PPE, germs spread quickly through touch. Other examples of how this could happen includes a handshake, taking a pulse, anything of that nature. Germs can also spread through shared patient care devices, such as glucometers, portable blood pressure machines, and stethoscopes. Devices do not need to be visibly contaminated with blood or body fluids for germs to spread. These devices should be cleaned and disinfected between each patient use, or you should be using dedicated patient care equipment. Examples of some germs commonly spread through touch are multi-drug resistant organisms, including MRSA and CRE. Other examples include hepatitis A, Clostridioides, scabies, and norovirus. So then the next pathway is splashes and sprays. So the splashes and sprays pathway occurs when respiratory particles or body fluids travel from an infected person to another person. These particles can carry germs that reach your eyes, nose, mouth. They get into your mucous membranes and cause infection. So splashes during oral care and coughing, sneezing, speaking, all of these are examples of how you can spread germs via splashes and sprays. Mr. Jenkins' oral care, for example, droplets could land on the gloves and gown of the staff that he's working with or on surfaces. These droplets can carry germs that spread through indirect contact. No matter what the disease is, if it spreads through splashes and sprays, you can protect yourself by using a face mask and eye protection or a face shield. So germs can travel farther if they're propelled by coughing and sneezing. And some examples of germs that can spread through splashes and sprays are influenza, rhinovirus, also known as the common cold, pertussis, and mumps. In long-term care facilities, germs spread when residents cough, sneeze, or breathe heavily in close proximity to others. So if Mr. Jenkins, for example, develops a cough or a fever after his hospital stay, staff must immediately consider a respiratory infection and evaluate whether precautions are needed to avoid transmission to other staff and residents. So next we have the pathway breathed in. So smaller particles can be breathed in. They're very small and can remain in the air for a long period of time. They also have the potential, because they're so small and remain in the air, to reach further distances. So this is why airborne precautions require special ventilation and respiratory protection. Either a mask or a respirator may be used depending on the germ. Some examples of types of organisms that can be transmitted by breathing in airborne or aerosolized particles includes meningitis, tuberculosis, measles, chickenpox, and SARS-CoV-2. In long-term care, respiratory germs spread when residents cough, sneeze, or breathe heavily in close proximity to others. And then our last pathway is clinical care. So clinical care can bypass or break down the body's natural defenses. These healthcare-associated infections can potentially be complications from medical interventions due to the intervention itself, error perhaps, or negligence. Clinical tasks that break down the body's defenses often include invasive procedures, which are medical procedures that involve entering the body by cutting or puncturing the skin or by inserting devices into the body. And again, examples include surgical procedures or, as we mentioned before, IV insertion. Some germs associated with surgical sites, catheters, and IV lines include E. coli, Staphylococcus, and Enterococcus. Strict adherence to aseptic technique and proper infection prevention measures is highly effective in preventing these infections. So when it comes to clinical care, it's important to make sure how we are doing our tasks and make sure that that does not put our patient at further risk for infection. So a few things we can do to decrease risks: cleaning your hands, wearing gloves if indicated, and adhering to cleaning and disinfecting protocols in your facility. All right, so we know about MDROs, we know how germs spread. Let's talk about what we can do about it. So over the next few slides, we'll review standard precautions, transmission-based precautions, and enhanced barrier precautions. So standard precautions we'll go over first is a set of infection control practices used to prevent transmission of diseases that can be acquired by contact with blood and body fluids. They apply to every resident in every interaction. These practices are based on the principle that all blood and body fluids, secretions, and excretions may contain infectious agents. The key elements of standard precautions include hand hygiene, appropriate PPE use, respiratory hygiene and cough etiquette, safe injection practices, safe sharps handling, environmental cleaning and disinfection, and reprocessing of reusable medical equipment. Infections prevented with standard precautions can include, but are not limited to, hepatitis, HIV, and Staphylococcus streptococcus infections. So think of all your patients as being potentially infectious. No matter how emergent the situation is, adhering to standard precautions and donning PPE is critical. Standard precautions are the universal baseline, whether infection is known or not. So thinking back to Mr. Jenkins and how this all translates into his care, what are some things that you would consider as a healthcare worker that fall within standard precautions and apply to Mr. Jenkins? Just everyday things that you would do for Mr. Jenkins that kind of falls under standard precautions? Any ideas you feel like sharing in the chat now that it's working? All right. Someone says gloves and mask. Thank you, Anthony. Yep, so gloves and masks, wearing PPE, and like doing a risk assessment, making sure you know what your what the potential is for the situation that you're dealing with. I'll throw another one out there. Hand hygiene, easy peasy, before and after all contact with patients, and in between and as needed, and anytime you think that you need it, or anytime your hands are soiled, after you go to the bathroom, after you eat, before you go to the bathroom. Hand hygiene all the time. We'll go over a few more. If it wants to work. There we go. So hand hygiene we covered, wearing gloves for wound care maybe because he has a wound, wearing a gown in contact with drainage likely, cleaning and disinfecting equipment between uses, properly disposing of contaminated materials. Perhaps you want to make sure you're doing appropriate laundry handling. So when you're handling laundry, you're not like shaking out his sheets, you're rolling it up in a bundle and carefully putting it in the laundry basket. Cleaning and disinfecting his room and all high touch surfaces so it can't, whatever he has, even if we know or don't know, can't spread to others, those sorts of things. So then we have TBP and EBP. So transmission-based precautions are used for residents with known or suspected infections. So when a resident develops symptoms such as diarrhea, fever, uncontrolled drainage, or a new rash, consider transmission-based precautions to prevent spread. Contact precautions may also be recommended in situations involving ongoing transmission or by health department recommendations. And I think by contact precautions, I actually meant transmission-based precautions. So transmission-based precautions could also be recommended in situations involving ongoing transmission, if there's an outbreak going on, if the health department recommends it. Enhanced barrier precautions is recommended for residents with novel, targeted, or epidemiologically important MDRO infection or colonization, even without active symptoms. And we'll review the three types of transmission-based precautions. So before you are examples of the visuals used to communicate the need for precautions and PPE based upon symptoms and or a confirmed pathogen. So if a patient requires transmission-based precautions, it should be clearly communicated with the care team, and signage should be visible at the door so that all who are entering can take appropriate measures. However, also remember that with standard precautions, you do a risk assessment prior to a procedure or task to make sure that there isn't any extra PPE or further PPE you might need in anticipation. So here we have the three posters in front of you, and you have the yellow poster for contact precautions. That's applicable for the pathway touch. You have the green poster for droplet precautions, which is utilized for the pathway splashes and sprays. And then the blue poster is airborne, which is used for germs that can be breathed in. So the first, contact precautions, is all about preventing the spread of germs through touch, whether that's direct with a resident or indirect through surfaces and shared equipment. So when we think of situations that would call for contact precautions, we think of things like C. diff diarrhea, norovirus, and MRSA infected wounds. One thing to keep in mind is that residents on contact precautions may need to eat in their room and avoid group activities until they're cleared from that infection. So that's a big change thinking about someone like Mr. Jenkins. So it's important to communicate clearly with the resident and the care team about why these steps matter. So for instance, if Mr. Jenkins develops new diarrhea while in a long-term care facility, contact precautions would need to start right away. That means staff should put on a gown and gloves before entering his room. Whenever possible, you'd have to use dedicated care equipment for residents on contact precautions. However, if equipment has to be shared, then you want to make sure it's clean and disinfected before and after each use. So then we have droplet precautions, and droplet precautions is initiated when staff and residents, when protecting staff and residents from germs that spread through splashes and sprays. Transmission usually occurs within close distances when those splashes and sprays can reach another person. And because of this, staff should don a surgical mask and face shield or goggles depending on the task. If the patient needs to leave their room, if appropriate and safe for the patient, they should wear a face mask as source control. Source control being you're protecting others as opposed to yourself. And then we have airborne precautions. So airborne precautions are for germs that can be breathed in, like tuberculosis, measles, shingles, or chickenpox. In long-term care settings, residents who require airborne precautions often need to be transferred to acute care facilities with appropriate isolation rooms. These are also known as airborne infection isolation rooms, AIIR. And these have negative pressure ventilation. Staff who take care of the patient must wear fit-tested N95 respirators when entering the rooms. So it's important to note that if you do have a resident on airborne precautions, they must be restricted to their room and cannot participate in group activities. And again, that resident will most likely be sent to an acute care facility where the hospital could accommodate those needs of an airborne infection isolation room better than a long-term care facility could. All right, so then we have EBP. An EBP, or Enhanced Barrier Precautions, is used in long-term care facilities. Enhanced Barrier Precautions is an infection control intervention designed to reduce transmission of multi-drug resistant organisms in nursing homes. Enhanced Barrier Precautions involves gowns and gloves during high contact resident care activities for residents known to be colonized or infected with an MDRO, as well as those at increased risk of MDRO acquisition, like residents with wounds or indwelling medical devices. So we are preventing spread from one resident to another. We're also decreasing the risk of using EBP of a resident getting an MDRO if they share these risks of wounds or indwelling devices. This precaution applies to long-term care facilities only and is not implemented within acute care facilities. EBP is a less restrictive adaptation of contact precautions in order to prevent the spread and acquisition of MDROs, but also just provide some freedoms within a place where residents are living. High contact resident care activities are those that require the use of PPE under enhanced barrier precautions. And these activities include dressing, bathing, transferring, oral care, wound care, device care, such as central lines, urinary catheters, feeding tubes, and tracheostomy or ventilator care, changing linens, and assisting with feeding when it involves close physical contact or is performed alongside other hands-on care tasks. Because these activities involve close physical contact and create opportunities for germs to move from one resident to another, it's important for staff to wear a gown and gloves for each of these tasks when caring for residents like Mr. Jenkins. So these images on the screen in front of you are taken directly from the CDC Enhanced Barrier Precaution Pocket Guide. This is a really great resource. I'll have Kelly share the link in the chat with you. It's a small little pocket guide that you can put in your, scrub pocket, wherever you want. Pull it out whenever you need to. Reminder and a reference to enhanced barrier precautions. And it includes when to use it, what PPE to use, and key steps to implementing it correctly in your facility. All the need to knows. So we've talked a lot about TBP and EBP. So we're going to kind of pull it all together and see how they compare, how they differ. So both TBP and EBP are built on top of standard precautions. They never replace the basics like hand hygiene and wearing the right PPE based on what you expect to encounter based on your risk assessment. With both, you'll need gowns, gloves, masks, and eye protection readily available and selected based on the anticipated exposure. Clear signage and thorough staff education are key so that everyone on the team knows what precautions are in place and how to protect themselves and others. And with both, hand hygiene must happen before putting on PPE and immediately after taking it off, and any time that you find that your hands are soiled. For either one to work well, the whole care team needs to be on the same page. And that means strong interdisciplinary communication and making sure precautions are documented in the resident's care plan. Regular competency checks and adherence monitoring help ensure everyone is applying them correctly. So at the end of the day, TBP and EBP share the same goal. Their goal is to protect residents from the spread of germs that could lead to infection or colonization, and to keep healthcare workers safe from picking up and passing along those germs. So where do they differ? TBP applies when an infection is suspected or confirmed. PPE is required every time you enter that room, and TBP often means that the resident can't participate in group activities and any movement outside the room is limited to what's medically necessary. EBP, on the other hand, is recommended for residents with MDRO colonization or infection, indwelling medical devices, or chronic wounds. In general, it is less restrictive than TBP. Residents are able to travel outside of their rooms as long as certain care is taken. They should perform hand hygiene and don clean clothing prior to leaving their room to join others. PPE is only worn during high contact care activities by staff, and this allows residents their freedom of movement and independence within their home. So let's add to our case scenario and pretend that Mr. Jenkins develops diarrhea. What precautions would we apply if Mr. Jenkins develops active diarrhea? Go ahead, and if you have an idea, put your answer in the chat. Good. Okay, so we're going to do transmission-based precautions and a step further, contact precautions. Yes. So following with what we know, if we were to go by his symptoms, contact precaution would need to be applied. How about when he recovers? When he recovers from his diarrhea illness, he's no longer deemed infectious with that. What precautions, if any, would he be on? EBP. Good, good. So once his diarrhea resolves, Mr. Jenkins will no longer need contact precautions. Instead, he will return to enhanced barrier precautions. And again, this is already applied to him because he's high risk for MDRO acquisition related to his Foley and his wound. And then, of course, he already has pre-existing MDRO colonization. So we would go with EBP. So these small changes in precautions seem really silly to us, right? Why don't we just put on a gown and gloves and put them in isolation? But these small changes in precautions matter because they help prevent unnecessary isolation while still protecting residents and staff. So let's just briefly touch on implementing these in your long-term care facility. Sorry, I'm losing my words. So in the next couple of slides, we'll look at the various things that are important when implementing TBP, EBP, and standard precautions in your facilities. So communication. Communication is an essential piece of precautions. So all staff who may be involved in patient care, from physicians to nurses to consultants to dietary to EVS staff, you must know how to protect yourself and the patient properly when you enter that room. Ways to do this include passing along the changes verbally in shift handoff, also writing it in shift notes, using clear signage near the patient rooms, real-time updates given to team members who may provide care within that shift and may not see that shift note, and communication with all consulting specialties that may come in, as well as people like podiatry or hairdressers that come in kind of like on a once a month basis, making sure you're updating them on what is safe for them to do and not to do and how they need to protect themselves and others. Clear, consistent communication always keeps everyone aligned. Part of communication we mentioned involves signage. So signs should be clear, they should be consistent within your facility, and they should be posted before anyone enters the room so that people can see it prior to going in. And they tell staff, students, volunteers, and visitors exactly which PPE to use and when. For transmission-based precaution signage, this should indicate whether the resident may attend group activities, And for enhanced barrier precautions in long-term care facilities, signage focuses more on risk-based PPE during high contact tasks. Also, to properly support PPE use, teaching cannot just occur once. It requires reminders, monitoring, and continuous coaching. So training at your facility should include onboarding PPE training, along with regularly scheduled trainings and competencies, as well as needed training. It's important that staff feel confident donning and doffing effectively and safely. It's also important that staff have the resources that they need. For example, going back to our scenario with Mr. Jenkins, we want to make sure that PPE is stored near his room and that it's readily available. And then that'll make it much more likely that staff will use it appropriately and consistently during their transmission-based precautions or EBP tasks. So this seems a little redundant, but as we discussed, in long-term care facilities, it's important to balance infection control and safety along with quality of life. So the reason why EBP was created was so that residents with wounds, devices, or MDRO colonization could still participate in activities that enhance their quality of life in what is their homes. So it's important to offer clear explanations to residents and their families to help them understand if you're putting someone on precautions, taking them off precautions, changing precautions, help them understand what's going on, what's being used, and why those precautions why those precautions are being taken place and like how those precautions will affect them, what that means for them. All right. So to summarize our whole case scenario from this webinar, we were with Mr. Jenkins when he developed diarrhea, which put him on contact precautions. And once his symptoms resolved, he transitioned back to enhanced barrier precautions. Staff continued to wear gowns and gloves during high contact tasks like bathing, dressing, transfers, and wound care. Outside of those activities, he resumed group dining and social engagement. However, even when we follow the right steps, there are some risks to breakdown in communication or education that can still lead to infection transmission. So my question for you is, how do we ensure effective implementation in our facilities when there's a new need for precautions? How do we ensure that everybody knows what's going on, everybody's on the same page? If you feel comfortable, go ahead and put some thoughts into the chat for me. What are successful ways that we can implement precautions in our facility? Make all TVP and EBP practices a part of facility culture. Very nice, yeah. Education, competencies, and rounding. That's great. Education, of course, is key, making sure that everybody knows what things mean and how to do it appropriately. Auditing, yep. Anthony, I appreciate you saying culture as well, because it is a culture. It wasn't even really mentioned in this presentation, but the general healthcare culture and making things less automated and just more of like, this is how we do it here, helps in healthcare when it comes to policies and protocols, making sure everyone's doing the right things effectively. So let's get these answers up. Okay. So again here, how can we assure that precautions are implemented effectively? PPE is well stocked, signage is clear and consistent, there's clear communication in handoffs and to contractors, documentation in writing and verbally, you're cleaning and disinfecting equipment or using dedicated equipment, implementation of isolation if needed, and quick recognition of the need for isolation or precautions if needed to prevent spread. These breakdowns can easily occur in long-term care facilities as we have many patients to care for. It's really important to always just go back to standard precautions go back to your risk assessment and the infection control basics that we know to help prevent infectious disease transmission in our workplaces. So key takeaways for today's session. Standard precautions are the foundation of safe care. EBP is recommended for residents with MDRO infection or colonization during high contact care activities in long-term care, and also those with indwelling devices. TBP is used for specific situations such as acute diarrhea, excretions or secretions that cannot be contained, or ongoing transmission of a known infectious organism. MDROs are a major health threat to residents in long-term care, and implementation of infection control actions such as standard precautions and EBP are recommended by CDC as an effective strategy to reduce the spread of MDROs in long-term care facilities. And as always, it's always important to follow your facility's protocols and policies when implementing any of these precautions. We do have a course if you wish to dive a little bit deeper on the implementation of enhanced barrier precautions, just enhanced barrier precautions, no TBP or anything with it, for long-term care facilities. And I will have Kelly share that link in the chat if you're interested. An important reminder that if you did not provide your email earlier in the chat, please enter it now to be added to our distribution list of upcoming trainings. You can also email Project First Line directly if you have any questions. You can click on the link to our live events link also through our website, and I'll have Kelly post that again in the chat box. And then lastly, please follow us on social media. We have YouTube, X, Facebook, Instagram, and LinkedIn. We post upcoming sessions. We post silly little memes. If you want to get to know our staff, go ahead and follow us. We do have 3 upcoming webinars. The first is Sepsis 1, presented by myself on Monday, May 11th at noon. Then we will have a measles and healthcare review on the prevention and control actions. And this will be done in the Spanish language. And that's presented by Kelly on Thursday, May 14th at 5. And lastly, we will have Sepsis 2, which is slotted to be our very, very last presentation from Project First Line Rhode Island. That will be presented by myself on Monday, June 1st at noon. Signups are available on our live event page, and we'll also throw that link into the chat for you to register if you want as well. We have quite a few references from today's session. They will all be sent to you in the post-session resources. 2 pages full. And again, just to remind everyone of the certificates of training and CNEs, please make sure that you do all of the requirements to receive it. So in order to receive your certificate of training, you must complete pre-session survey, participate in the session, and complete the post-session survey. A link for the post-session survey will be sent to you via email on April 28th and will be available until May 4th at midnight. Once you complete the requirements, a certificate of training will be emailed to you in PDF form on Monday, May 7th. For EMS and dental providers, this can be used towards 1 hour of continuing education credit. And please be sure if you're looking to receive CNE credit that you complete the post-session quiz that will be emailed to you tomorrow with the rest of your post-session documents. So before we move along to our Q&A, I would ask that you please take some time to complete our end of session feedback poll. This does help us to improve your learning needs and create future courses. Take a minute to do that. And while we do this, I will invite Dr. Kearney to come on screen. You can introduce yourself if you want to, since I didn't have you do that earlier. And we will take a look and see if there's any questions. Thank you all so much, and I hope to see you next time. Take care.